Hi. All right, it's midnight. Midnight on day one of the assignment being due. We're doing assignment 4 for PYC3702. It's nice and short and sweet, thank God. All right, let's go. We're looking at trauma and stress-related disorders. Okay. So there we have our South African shack life. You can see there's a lot of trauma there just by looking at that picture. I've used mainly pictures from movies. Keep it light. Okay, so you need to know what a stressor is. A stressor is the thing that provokes the stress. Okay, the stress is the internal state. It's the internal psychological and physiological response to the stressor. So symptoms of stress in descending order of prevalence: irritability, anger, fatigue, feeling nervous or anxious, headache, depression, muscle tension. Some people are fairly resilient, whereas others develop long-lasting symptoms and problems, such as PTSD. Okay, so which is which, trauma or stressor-related disorder? So there's 3 disorders we look at on this page. The adjustment disorder, which is a stressor-related disorder, along with reactive attachment disorder. Remember, that's when the children push away contact. And disinhibited social engagement disorder, another stress disorder from childhood where the children have no boundaries and are willing to go off with any adult that will have them. Okay. Then we're going to look at 2 trauma-related disorders: acute stress disorder. Unfortunately, stress and trauma get mixed around there. And post-traumatic stress disorder. Okay. Adjustment disorders. Okay, the textbook doesn't really do a great job, but luckily the Unisa tutorial notes really fill this out. Okay, so an adjustment disorder is when you are not adjusting to a life stressor. Adjustment disorders can accompany any medical disorder and most mental. Associated with an increased risk of suicide attempts and have a high rate of completed suicide. So they are important and significant. They also involve subjective distress and impaired functioning like any other disorder in the DSM-5. Possible stresses: interpersonal problems, betrayal, loss, ending of a relationship. Recurrent stresses such as exams and assignments, continuous stresses, disability, crime, chronic pain. Developmental events, leaving home, having a baby, divorcing, losing a job, etc. Okay, also stresses related to the death of a loved one. There's an alternative disorder category that it could fall into, which would be persistent complex bereavement disorder. Okay, so to diagnose adjustment disorder, a person needs 1. Exposure to an identifiable stressor that caused the emotional behavioral symptoms within 3 months of the event, a kind of an out of proportion, so-called out of proportion response to the severity of the stressor that results in impairment and distress. And the symptoms last no longer than 6 months. If they last longer, you have to have a different diagnosis. Okay. So it can be differentiated from other diagnoses. The stressor is not intensely life-threatening, such as PTSD or acute stress disorder, but can be terribly distressing. It's not always a minor thing. And it may be out of proportion, so it's regarded as an abnormal response to stress. It's not normal and adaptive. It lasts between 1 and 6 months, unlike depression and anxiety disorders, and starts within 3 months of being exposed to the stressor. The prevalence is quite high, up to a third, almost 30% of people seeking help. So it is significant, and it's quite common for people with a life-threatening medical diagnosis. It can be quite devastating and stressful for people. Also much more common amongst women and amongst the disadvantaged. Okay, then we have acute stress disorder. This is actually a trauma disorder. Acute here is in the medical sense of short duration and intense. Okay, from the root meaning sharp. Okay, so acute stress disorder is very similar to PTSD. The differences are basically duration and some of the negative thoughts and cognitions. So let's go through this in detail. It's characterized by flashbacks, hypervigilance, and avoidance symptoms lasting up to 1 month. Okay, so for the acute stress disorder, short and intense, up to 1 month. If it continues for longer, it's PTSD. Okay, traumatic stressor. This is the difference between a trauma and a stress disorder. Traumatic stressor involves actual or threatened death. Okay, if you're actually dead, you're not going to have a traumatic condition. Serious injury or sexual violence. Okay, so this can be through direct experience, witnessing the event happening to others, learning that it's happened to a close family member or a friend, or experiencing repeated or extreme exposure to details of traumatic events, such as first responders, paramedics, and so on, being exposed to constant trauma. Okay? It has 9 or more symptoms that involve intrusion symptoms. There's 4 listed here. Memories coming back all the time, recurrent distressing dreams, dissociative reactions such as flashbacks where you are reliving the trauma or may even lose track of where you are because the trauma is so vivid. Okay, also stress responses to cues that remind you of the events, either internal, like your heart racing, or external, like sounds, colors, people, etc. Negative mood, a persistent inability to experience positive emotions. We'll see when we get to PTSD, they've got a lot more items in the negative mood. Other than that, this list, as far as I can see, is identical. Okay, presented differently, but it's the same list. Dissociative conditions. Okay, so that's when you either dissociate because so there's 2 forms of dissociation. Let's see, there's an altered sense of reality of yourself. So you don't feel like you're in your own body or you're witnessing yourself from outside. This would include being in your daze, time slowing down, and being unable to remember important aspects of the event due to dissociative amnesia. So dissociative symptoms go into derealization and depersonalization. Okay. Avoidance symptoms. Avoiding the distressing memories, the thoughts, the feelings, and avoiding external reminders, places, people, things, sounds that may trigger memories, thoughts, and feelings about what has happened. Then you've got arousal symptoms. Okay, so here you've got sleep disturbances, very common, irritable behavior and angry outbursts, hypervigilance, meaning you're constantly watching out and easily frightened, difficulty concentrating, exaggerated startling response. When the toaster goes pop, you jump. Okay. Over half of the people with acute stress disorder have symptoms lasting longer than a month, and then they go on to receive a PTSD diagnosis. So the 2 are really very, very, very similar. Okay? Post-traumatic stress disorder, PTSD. Okay, this is a condition characterized in exactly the same way as acute stress disorder. The extreme trauma is defined in exactly the same way. Here, the only difference is, okay, it says here we only need 1 or 2 symptoms, which is strange because for acute stress disorder we needed 9. But let's look at the negative alterations in cognition and mood that are listed here for PTSD. Okay, profound, exaggerated beliefs and expectations that don't shift about yourself and the world that are negative. Okay, distorted cognitions that cause you to blame yourself or others, so you can't let go but you can't find peace with it. Persistent negative emotions, fear, anger, horror, guilt, shame, feeling dirty, etc. Lack of desire to do things, feeling detached and estranged from others, like you can't relate to anyone, you don't want to let anyone close to you, and persistent inability to experience positive emotions, the joy that may go out of your life. Okay, there's something very odd with the prevalence numbers. I don't know what it is. PTSD is twice as high for women, but the evidence that it's physiological doesn't make sense, because the exception to that is for rape. In men, the level of PTSD for rape survivors is much higher than it is for women. So that indicates it's not a physiological issue. It could be to do with gender expectations of how to handle stress, how to handle trauma, got to do with agency, control, and self-image and all that stuff. That's my personal opinion. Okay. Right, it may be with or without dissociative symptoms. Depersonalization, I'm not me, I'm not the person that is me, okay? Time moving slowly. Derealization, this is not real, it feels like a dream, it's distorted and distant, okay? And there may be delayed expression of PTSD, which could be 6 months or more after the event actually happens, okay? All right, so there's a little assignment you can do. A little exercise. I just put some multiple choice questions into the course. There's not many. I don't see it being emphasized in the exams. Okay, so let's look at why some people develop PTSD or acute stress disorder and others sail through quite the same events without. Okay, so if there are severe physical injuries or personalized trauma that is directed at you personally, increased risk. So stroke, head injuries, injured hands and feet, major burns, rape and assault all carry increased risk. The closer the perpetrator is to the survivor, the greater the chance that PTSD will develop. It's personal. Okay, then also people with negative and global cognitive styles, childhood trauma and complex trauma. If the person has had trauma already that they haven't dealt with, the chances of PTSD go right up. There is a genetic vulnerability, and lack of social support is a major factor. Okay, so let's break this down. All right, we're looking at, there is a genetic base for some. The amygdala, because it manages fear. Okay, it tells your sympathetic nervous system to get ready to flee or fight. Then there's also the HPA axis, the hypothalamic pituitary adrenal axis, which releases the hormones, the epinephrine and the cortisol, to tell your body to fight or flee. This comes into the psychophysiological conditions that are right at the bottom of this, which is just logical. It'll drive up your blood pressure, your blood sugar, your heart rate. Okay? In people with PTSD, the amygdala does not switch off. You don't get that feeling of I am safe, the danger is past. You remain in a state of fear. So fear is not inhibited as it should be. Psychological dimension. Pre-existing conditions such as depression, anxiety, negative emotions such as anger increase the possibility of developing PTSD. Ruminating may increase the reaction to it. Cognitive patterns such as generalizing, helpless, fearful, dysfunctional thoughts, catastrophic interpretations of trauma. All of these things will make it more likely that you will get a trauma disorder and or a stress disorder. Social dimension, major factor in how a person can process this and their odds of successfully coming through a stress or trauma. If you have a strong support system, it helps you recover and it stops PTSD because it releases endorphins, you release fear and anxiety because you have support. But a complex trauma family history with lots of childhood stresses and traumas contributes very significantly to developing trauma-related disorders. Lots of family conflict, or if you're maltreated, or if you're overprotected, this is also factors. Okay. Sociocultural dimension. Okay, women more than men, twice as likely, except in rape. Ethnic differences, most amongst the Latino Hispanic population in America and lowest amongst Asian Americans. This is probably because of broader social conditions and discrimination, high levels of violence, broken families, migrants, etc. Okay. Treatment of trauma-related disorders. Okay, antidepressants seem to help like 60% of people, but most of these people do not get a full recovery from antidepressants, and there were various other medications that didn't seem to really be concrete. Psychological interventions help extinguish the fear. There's exposure therapy. Just simply reimagining and retelling the story can help you to process the trauma. It's very effective for most people. Cognitive behavioral therapy, trauma-focused cognitive behavioral therapy. You focus on the trauma and you change the cognitions about what happened. You normalize it and so on and so forth. And give people strategies for supporting themselves and for reaching out and all that. Okay, then EMDR is an interesting one. It's actually quite effective. What it is you move either your eyes or you get a tactile or an auditory sensation, or left, right, left, right, left, right, as you narrate what happened to you. Because a traumatic memory is almost like you're reliving it. It's not really part of a biography. It's just like, oh. Okay, so as you do that, it shifts the way the brain processes the memory so that it becomes biographical and something that you're simply narrating rather than reliving. Okay, you also replace negative cognitions with positive ones in all of these psychological interventions, I would say. Okay. Right, looking at psychophysiological disorders and symptoms. Any physical disorder that has a strong psychological basis or aspect, and you cannot actually distinguish and say that this or that physiological disorder has no psychological aspect, to be honest, because they all do. All conditions respond to stress or happiness. Broken heart syndrome is an actual condition. You get such a big shock, it sends the heart into cardiac distress and it can kill you. Okay, your immune system is highly sensitive to stress. Coronary heart disease, because your blood pressure goes up with stress. Okay, hypertension, same, blood pressure goes up. Heart rate goes up with stress. Your hormones push your heart rate up, they put pressure on your heart. Headaches, also hypertension can cause a migraine headache, a tension headache, or a cluster headache, which is a very painful, usually only on one side, type headache. And asthma also responds intensely to stress. Okay, so that's the end of that. Good luck for the exams. Don't forget to like, subscribe, and share, and I might see you next week. Okay, bye.